of the spine in a patient who will be affected with metastatic prostate carcinoma. The red represents the marrow elements there, the white, the intervertebral discs, and note the scattering of white punctate lesions throughout the marrow there, representing the metastatic prostate carcinoma. Issues related to the prostate, including infections, benign prostatic hypertrophy, and finally prostate cancer. The tumors that affect the testes can be broken down into two main groups: germ cell tumors, which make up approximately 90% of the tumors that are encountered in the testes, and non-germ cell tumors. The non-germ cell tumors being things such as Leydig cell tumors, Sertoli cell tumors, and the granulosa cell tumors. We'll spend the majority of our time, however, concentrating on the germ cell tumors, which have different responses to radiation and which spread differently through the body if not treated. Germ cell tumors, in terms of epidemiology, have an incidence of approximately 6 per 100,000 people. They tend to occur within a younger age group ranging anywhere from the mid-teens to the mid-30s and are more common in white males. The risk factors, one of which you know about already, include cryptorchidism, and remember that the risk factor for germ cell tumor occurs even after the cryptorchidism is corrected. There are various genetic factors involved, and anything that leads to testicular dysgenesis. The sort of clinical vignette that one might encounter is as follows. You could have a 36-year-old male who presents with progressively painless enlargement of his left testicle. Physical examination reveals a walnut-sized, non-tender, firm mass at the upper end of the left testicle. The mass does not transluminate. Laboratory examination reveals normal levels of AFP and LDH. This clinical history is important for a couple things for you to notice as you prepare to take USMLE Step 1. First of all, as with other clinical vignettes, note the age of the patient. This will often help you begin to narrow down the possibilities, both in terms of possible infections, inflammation, and possible tumors. For example, one would not expect a 36-year-old to be initially presenting with a congenital disorder of some type. Also note here the description of the mass. It does not transluminate. We would expect more benign lesions of the testes and epididymis to transluminate, things such as hydrocele. And finally, note the important role that lab tests are going to play here. We will spend some time today talking about the various ways in which markers such as AFP and LDH, or things such as beta-HCG, are elevated by different tumors, and how this can help you decide which tumor it is you're dealing with, even without a biopsy. Now, seminomas are the most common type of germ cell tumor, making up approximately 40% of these tumors. Think of this tumor when you're dealing with a patient in their 30s with a painless enlargement of their testes. These are malignant, and they are analogous to the dysgerminoma that you will see within the female reproductive system. Perhaps most importantly, these tumors are radiosensitive, and hence one has a very powerful tool in your armamentarium for dealing with them. In terms of markers, these sometimes release HCG, although we tend to associate that marker more with the tumor choriocarcinoma. And again, as we've emphasized earlier, cryptorchidism increases your risk for developing this tumor. Embroial carcinoma is the second most common form of germ cell tumor. It presents in a slightly younger age group, those patients who are within the age of 20 to 30. Often presents with pain, unlike seminoma, or, unfortunately, with metastases. And again, HCG is sometimes elevated. The pathology here is of a variegated, poorly demarcated tumor with areas of hemorrhage and necrosis. Grossly, the tumor looks malignant. The cells can grow in a variety of forms, including glandular, alveolar, or tubular patterns, sometimes even taking on papillary convolutions. Undifferentiated forms of the embryonal carcinoma can present simply as sheets of cells, or there can be syncytial cells that immunostain for HCG, AFP, or both. This slide simply shows what an embryonal carcinoma might look like when cut across on gross section, and I think you can appreciate its malignant appearance. Note the various areas of hemorrhage and necrosis, things that tell you this tumor is most likely going to be a bad actor. Yolk sac tumor are germ cell tumors that peak more in infancy and early childhood. So again, go back to your clinical vignettes and note the age ranges that they give you. If they're talking about a patient in their 20s to 30s, be thinking about a seminoma or an embryonal carcinoma. However, if you're dealing with an infant, think yolk sac tumor. This is the most common testicular tumor in infants and children up to 3 years of age. And again, as the seminoma is analogous to the dysgerminoma, the yolk sac tumor is analogous to the endodermal sinus tumor. In general, these tumors have a very good prognosis, and again, here our lab markers are going to be important. The yolk sac tumor tends to produce AFP, which tends to be the characteristic lab marker that we use to determine what sort of tumor is present. Choriocarcinoma is a highly malignant form of testicular carcinoma, which is characterized by being comprised of both cytotrophoblasts and syncytiotrophoblasts. Here, the classic lab finding that people tend to associate with the development of choriocarcinoma is increased levels of HCG. And both in male and female patients, you may find yourself following levels of HCG to determine if the tumor has been completely excised and or has reoccurred. This tumor is difficult to deal with because, unlike things such as seminoma or embryonal carcinoma, there tends to be no testicular enlargement. Indeed, at times there's only a very small palpable nodule present. Hemorrhage and necrosis are extremely common, similar to what one may see with an embryonal carcinoma. The term teratoma refers to a group of complex tumors that have cellular organoid components reminiscent of normal derivatives from more than one germ cell layer. In terms of pathology, these are usually large tumors that have a heterogeneous appearance due to the numerous components that are present from various germ cell layers, with solid, sometimes cartilaginous, and cystic areas all present within the same tumor. There are 3 variants of the teratoma. The mature teratoma, which it is important to distinguish is always considered malignant in males, but is benign in females. The immature teratoma, which is malignant in both males and females, and teratomas with malignant transformation, where what one has is a mature teratoma where one of the components has undergone malignant transformation. This slide simply tries to show an example of a teratoma. Note both the solid and cystic areas. If we were to look closer, we would probably see foci of cartilage, possibly bone development, areas with keratinaceous cheesy material consistent with the development of epidermis, and possibly the development of sebaceous material and hair. Mixed tumors represent 60% of testicular tumors and are composed of more than one tumor cell pattern. The most common mixture that one will see is a mixture of a teratoma, an embryonal carcinoma, and a yolk cell tumor. The prognosis here for these patients with a mixed tumor is determined by the least mature element that happens to be present. Thus, a patient with a mature teratoma, but that also has components of a highly malignant choriocarcinoma, their prognosis will be determined by the presence of the highly malignant choriocarcinoma rather than by the possibly more benign mature teratoma. Clinically, what one needs to be concerned about when one's looking at these tumors is with the seminoma, remember that these are radiosensitive, so that is your primary therapeutic option. They also tend to remain localized to the testes for a long time, and when they metastasize, they like to go to the local lymph nodes. The non-seminomatous germ cell tumors, on the other hand, tend to be radioresistant. They present with painless enlargement of the testes, and 60% of these patients, unfortunately, present with advanced disease, with these tumors metastasizing early and hematogenously. Lymphatic spread, for those tumors that do spread lymphatically, is common. They like to go to the retroperitoneal para-aortic nodes. For those tumors, the non-seminomatous ones that like to spread hematogenously, the lung tends to be one of the common sites that are metastasized to early. However, these tumors can also go to the liver, brain, and bones. In terms of our markers, remember your yolk sac tumors will tend to produce AFP, while choriocarcinoma is infamous for its production of HCG. The non-germ cell tumors make up a much smaller percentage of the tumors that one will see in the testes. They consist of things such as Leydig cell tumors and Sertoli cell tumors. Leydig cell tumors are derived from testicular stroma and are characterized histologically by the presence of the intracellular Ranke crystal. They are similar to the Sertoli Leydig cell tumors that one will see in the ovary and are most often benign. The interesting thing about the Leydig cell tumor is that they can make androgens or androgens and estrogens, and hence perhaps what one may see first in these patients is the presence of physical features created by the presence of these androgens or estrogens that give clues to the presence of the Sertoli cell tumor. They can arise at any age, and given their benign nature, most often present as well-circumscribed nodules. Sertoli cell tumors are derived from the sex cord stroma, again are similar to the Sertoli-Leydig cell tumors of the ovary, and similar to Leydig cell tumors tend to be small, well-circumscribed nodules with homogeneous gray-white to yellow-cut surface and generally are benign. Testicular lymphoma is a tumor that you will most often see within elderly individuals and account for only about 5% of testicular neoplasms. However, testicular lymphoma is the most common form of testicular cancer in patients over the age of 60. Most of these will be diffuse large cell lymphomas and unfortunately carry very poor prognosis. Other tumors or lesions that one can see within the tunica and vaginalis includes things such as hydrocele, hematocele, and chylocele. Here, your physical exam is going to be very important, as most of these will transluminate compared to the non-translumination that we mentioned earlier that you will see with things such as seminoma. Hydrocele simply refers to the accumulation of clear serous fluid in the tunica vaginalis. Again, transillumination will reveal the clear translucent substance present within this lesion. Hematocele, as the name implies, simply refers to the accumulation of blood within the tunica vaginalis. This is an uncommon condition, and one will want to ask the patient about whether there's been any direct trauma to the testes or torsion of the testes with possible hemorrhagic suffusion into the surrounding tunica vaginalis. Finally, chylocele, as the name implies, is due to the accumulation of lymph within tunica vaginalis. You'll see this in patients who for some reason have obstruction within the surrounding lymphatics, say those who are infected with conditions such as elephantiasis. This now brings us to the final topic within the male reproductive system, the prostate. Inflammation can frequently affect the prostate and can be both of the acute and chronic form. Acute bacterial prostatitis is due to generally things such as E. coli, gram-negative rods, enterococci, and staphylococci, and can present as acute focal or diffuse separative inflammation in the prostate itself. Pathogenesis is thought to be intraprostatic reflux of urine from the posterior urethra or urinary bladder, or it can be due to possible hematogenous routes from distant foci of infection. Also, this can occur after surgical manipulation of the urethra or prostate. The patient will present, not surprisingly, given that they have inflammation, with fever, chills, and dysuria, and the prostate on exam will be described as tender and boggy. Chronic bacterial prostatitis, these patients will present with low back pain, dysuria, and perineal and suprapubic discomfort, very similar to patients who might be presenting with cystitis or UTI. Chronic bacterial prostatitis is thought to be due possibly to recurrent urinary tract infections with the same organism. You document it by documenting leukocytosis within expressed prostatic secretions, along with positive bacterial cultures from the prostatic secretions. What one sees histologically is an aggregation of a variety of inflammatory cells, including lymphocytes, plasma cells, macrophages, and neutrophils within the prostatic substance. The most common form of prostatitis, however, is what's called chronic abacterial prostatitis. This, unfortunately, is clinically indistinguishable from chronic bacterial prostatitis, and one is left trying to determine this based on clinical history, as the patient will not give any history of recurrent urinary tract infections, and you will see that they have pyuria, but cultures will be negative. This has left clinicians scratching their heads as to what the possible etiologic agent could be involved, and various authors have pointed to things such as chlamydia trachomatis, ureaplasma urolyticum, and possibly some of the forms of mycoplasma. Benign prostatic hypertrophy increases with incidence over time. So if you look at a population of males, it is present in 20% of males at age 40 years, but by the time they get to age 70, over 90% of males in that population will be affected in some way by BPH. This pathogenesis is due to the production of dihydrotestosterone, DHT, which is the ultimate mediator of prostate growth. DHT is created from testosterone by the actions of 5-alpha reductase and can act in an autocrine fashion on stromal cells or in a paracrine fashion by diffusing into nearby epithelial cells. We treat BPH in part by inhibiting 5-alpha reductase, which can reduce DHT content in the prostate and decrease both prostatic volume and urinary obstruction. There does not appear to be any relation between the presence of BPH and the risk for prostate cancer. This slide merely shows an example of a prostate cut on cross-section that shows the presence of well-defined nodules bulging out from the prostatic surface, classic gross features for benign prostatic hypertrophy. Now, the proximity of these nodules should be noted to the urethra and accounts for the urinary obstruction seen in cases of BPH. BPH, remember, is usually periurethral and in the transitional zone. Hence, you can't determine it as well on rectal exam, but its presence to the urethra again leads to the urethral obstruction and urinary retention that one sees in these patients. This is that same section simply seen on microscopic cross-section, and what one sees on this whole mount are nodules of hypertrophic glands on both sides of the urethra, seen there in the middle of the slide. Clinical features of BPH: compression of the urethra leads to difficulty in urination. These patients thus can present with distension and hypertrophy of the bladder, possibly the development of diverticuli, infection of the urine, and development of cystitis. What these patients will complain about is frequency, nocturia, and difficulty in starting and stopping their stream of urine. Sometimes they will get overflow, which results in dribbling and dysuria. This now brings us to the topic of prostatic carcinoma. An incidence of 69 per 100,000 males in the United States, risk factors being age, ethnicity with a higher incidence in African Americans than in Caucasians, and family history. The majority of prostatic carcinomas will arise in the peripheral zone, thus we can detect it on rectal exam. Compare that to BPH, which tends to occur more within the middle and periurethral zone of the prostate, and hence is not as detectable on rectal exam. The neoplastic tissue is described as gritty and firm. Prostate cancer likes to spread by a variety of routes, generally through direct local invasion and hematogenously and to lymph nodes. Prostate cancer is also known to spread by the perineural routes, spreading through nerve rootlets found within the prostate itself. Local extension most likely involves surrounding structures such as the seminal vesicles and the base of the urinary bladder. Hematogenously, it will spread to the bones and can be one of the blastic tumors that one sees, in addition to breast cancer. The great majority of these are going to be adenocarcinomas, and grading is very important because there is good correlation between prognosis and degree of differentiation. Those of you who go in pathology will make extensive use of the Gleason grading system to determine the grade of the tumor. What is seen here is simply a classic photomicrograph of a well-differentiated prostatic carcinoma, demonstrated crowded back-to-back glands lined by a single layer of cuboidal cells. As the tumor increases in grade, it decreases in the amount of glandular differentiation until only single, very anaplastic cells are present. This is cross-section diagnosis in patients with prostate cancer. One looks for increases in carcinoma. The red represents the prostatic acid phosphatase increases when the tumor invades, becomes metastatic. The scattering of white phosphatase lesions throughout the disease, representing the metastatic phosphatase levels, not surprising, will increase with the presence of bony mets. Prostate cancer responds to a variety of treatments, including surgical resection, radiation, and endocrine treatment. And this ends this section of the Falcon Review for Pathology for USMLE Step 1, Male Review.